أستاذ الفاضل أستاذ الدكتور منتصر زيد. دكتور منتصر أحد الفيجرز الموجودة في مصر والعالم العربي في النفرولوجي فيلد، وكان رئيس القسم السابق في طب اسكندرية، والنهارده هيكلمنا على الهوم دايليسيس opportunities and safety and challenge. اتفضل دكتور منتصر.
Thank you, Mr. Chairman, for this nice introduction and my lecture about home dialysis. After the introduction of Professor Dr. Hisham Said, my lecture is just an introduction to invite more nephrologists to invite more patients for home dialysis. In the early days of dialysis, because of lack of existing inter-center infrastructure, home hemodialysis was frequently used to expand dialysis programs. And recently, home hemodialysis has been thrust into the spotlight of kidney care program once again. Perhaps it is not surprising that the kidney community's interest in home hemodialysis has been revived, especially during the COVID-19 pandemic. The COVID-19 pandemic has emphasized the importance of enabling greater numbers of patients to perform dialysis at home, given that dialysis patients are at high risk for developing severe COVID-19 outcomes compared with the general population, and treatment in a dialysis center challenges effort to physically distance. Recent Canadian and Italian data demonstrated that patients receiving in-center dialysis were up to 3 times more likely to test positive for COVID-19 than patients receiving home dialysis. The US RDS recently reported that the COVID-19 hospitalization rate for patients undergoing in-center hemodialysis was 3 to 4 times that of patients receiving BD and home hemodialysis. And these observations have prompted a sense of urgency among clinicians and advocates to find immediate ways to make home dialysis more available for patients with kidney disease. The pandemic has shed light on many long-standing obstacles to home dialysis access that limit uptake. The number of patients who use this therapy has still lagged far behind the in-center hemodialysis. In the United States in 2016, only 1.8% of prevalent patients were treated with home dialysis, and only 0.3% of patients who began dialysis started on home dialysis. Among other benefits of home hemodialysis, it gives patients greater freedom from rigid schedules currently mandated in modern hemodialysis centers, and allows for more frequent and customizable delivery of therapy to meet individual patient needs and demonstrable quality of life benefit. However, despite these benefits, several barriers still remain for patients and providers interested in using home hemodialysis therapies. One of the most important factors that determine success in home hemodialysis is patient motivation. Patients who are strongly motivated to perform dialysis at home are often the most successful. Motivation to embrace more home dialysis is modifiable through direct patient education, appropriate counsel from physicians, and attention to patient concern. Another important factor in home hemodialysis success is motivation of the dialysis provider and the support system of the dialysis unit. Remote monitoring system can help the interdisciplinary care team recognizing potential problems that the patient may be encountering at home before they develop into more serious issues. Routine visits or checkups with a physician can be conducted via telehealth to decrease patient burden of travel and save time. Unfortunately, significant disparities exist in access to reliable internet and cell phone coverage in certain rural areas. Some of the benefits which will be gained from home hemodialysis versus in-center hemodialysis: improvement in blood pressure control, regression of left ventricular hypertrophy, superior phosphorus control, better quality of life, fewer symptoms of fatigue, less washed out sensation following dialysis, lower medication burden, improved pregnancy outcome, and dialysis weekend can be avoided at home with more frequent treatments. There are many challenges in arranging for safe dialysis at home. Concern can develop from patients regarding the safety of performing home dialysis in home while isolated from medical staff. Ability to perform needle cannulation is often cited at the forefront of barriers to patient confidence. Burden of therapy, physical space or housing limitation, availability of support to perform the treatment, caregivers fatigue and the patient or caregiver burnout are common and often go unrecognized by healthcare professionals. Physicians prescribing home hemodialysis need the full support of the interdisciplinary team to address the social and technical obstacles that patients will encounter. Although the initial investment is high from the patient and the dialysis unit, dividends are based the longer the patient is able to continue in home. Cost for home hemodialysis has been quantified internationally and indicates that the cost is in between that of in-center hemodialysis and peritoneal dialysis. These are the three types of machines commonly used in home hemodialysis: the conventional one and the Talbot system, and also the next stage system. The conventional dialysis machine can be performed at home. In addition to dialysis machine, a portable reverse osmosis water treatment system is used for water purification. Home hemodialysis with a conventional machine can be prescribed similarly to that prescribed in hospital. Alternatively, prescriptions can be modified to meet patients' needs. Short daily dialysis or nocturnal dialysis is an option for patients for whom there is concern for persistent volume overload or a need for increased solute clearance. The typical conventional dialysis home prescription, 5 to 6 times treatments per week. For short daily dialysis, 2 to 3 hours, and for nocturnal dialysis from 6 to 8 hours duration. Blood flow rate from 300 to 400 for short daily dialysis and 200 to 250 for nocturnal sessions, and dialysate flow rate from 500 to 800 for short daily sessions and 300 milli per minute for nocturnal sessions. Dialysis can be performed every other day to avoid the typical in-center 2-day break dialysis weekend, which is usually associated with sudden cardiac death, and schedule flexibility is a major benefit of conventional home dialysis. The Tableau machine is reported to be relatively easy to set up and has an incorporated reverse osmosis system. It can be used more like a traditional hemodialysis machine, but blood flow rate is limited to 300 milli per minute. In addition, it has a heat disinfection system for daily disinfection and once weekly chemical disinfection. This is a Tableau machine with incorporated reverse osmosis system in the machine itself. The next stage, system 1, is the first and only truly portable hemodialysis system cleared for home use in the United States, including solo hemodialysis during waking hours and nocturnal dialysis while both the patient and care partners sleep. It was specifically designed for patients to use in their homes and small enough to allow patients to travel and bring their treatment supplies with them. The setup includes a cartridge that contains tubing and filter. The circuit is closed circuit. The next stage prescription requires a different thought process than a typical dialysis prescription. The machine uses slower blood flow rate and a fixed dialysate volume, so the prescription is written in a way that is unique to the technology and at times confusing to providers of conventional hemodialysis. The prescription calls for a total volume of dialysate to be used similar to peritoneal dialysis, blood flow rate and ultrafiltration rate similar to hemodialysis, and the flow fraction is unique to this type of machine. Based on those parameters, the blood flow rate and time of treatment are determined by the machine. Flow fraction is simply the ratio of dialysate compartment flow to blood flow rate, and the machine relies on the concept of water-efficient dialysis, which occurs by slowing the ratio of dialysate flow to blood flow, a ratio known as flow fraction, and allowing dialysate to become more saturated with toxins over time. Dialysate flow rates are typically in the range of 100 to 300 milli per minute, depending on version of the machine used. The system 1 maximum flow rate can reach 12 liter per hour or 200 milli per minute, and system 1X maximum flow can reach 18 liter per hour or 300 milli per minute. And dialysate can come from preformed bags or from a water purified system, which is called the pure flow system. This concept is fundamentally different from traditional dialysis, which relies on a large volume of dialysate and the fast blood flow rate to increase diffusive gradient and improve dialysis efficiency from a toxin clearance standpoint. For a given treatment, determine dialysate volume, blood flow rate, ultrafiltration rate, and the flow fraction, and the machine will then run the duration. The water treatment system for typical conventional dialysis treatment for 4 hours require dialysate flow rate of 500 milli per minute, about 120 liter per hour. The slower the dialysate flow rate using the next stage technology allow for smaller and more compact water treatment system, the pure flow system, which is most commonly used at home for dialysate preparation. And this system uses the deionization, among other filters, for purification of water. The conventional dialysis machine water must be pre-treated with a separate mobile water purification system in home. The Tableau system has its own internal water treatment system and is similar to conventional water treatment system. It is contained in the machine itself and not separate from the device that performs the dialysis therapy. If the source of water has a high sediment content, then additional filters may be needed for the machine to perform dialysis perfectly. This is the next stage pure flow purification backwater purification system. As regards anticoagulation of the circuit during home dialysis, it is usually achieved through bolus dosing of heparin at the start of dialysis treatment session. Patients undergoing extended dialysis treatment more than 3 to 4 hours or nocturnal hemodialysis often will need more than one bolus of heparin to achieve circuit patency for the duration of the session. Options for extended anticoagulation include hourly infusion of heparin or longer-acting pre-dialysis low molecular weight heparin. For vascular access for patients who are already undergoing in-center dialysis, learning to cannulate the access while undergoing routine in-center hemodialysis can allow a head start to less training burden when they present for instruction for home dialysis unit. Tunneled hemodialysis catheter have been found by some groups to be an acceptable access type, especially for nocturnal hemodialysis with a lower risk of infectious complications than that happened in center hemodialysis. Arteriovenous fistula are the vascular access of choice, but special care must be applied to nocturnal hemodialysis. The cannulation technique, buttonhole versus sharp cannulation, also needs to be considered in home hemodialysis patients. Buttonhole cannulation is associated with increased infectious risk without clear evidence of improvement in cannulation pain. Buttonhole cannulation may allow for shorter training time and easier cannulation in certain patients. Management of access infections depend on the type of infection and the clinical presentation of the patient. Fever and bacteremia, which can be treated with clinically appropriate antibiotic therapy for a minimum of 4 weeks and can be extended to 6 weeks for Staph aureus infections or if there are metastatic complications. Cellulitis or localized exit site infection can be treated with appropriate antibiotic therapy for 2 weeks or longer. Any access infection should be accompanied by retraining the patient and the care partners on access cannulation to identify potential lapse and in technique and reinforce a sterile technique for cannulation. Successful initiation and continuation of hemodialysis, home hemodialysis requires a motivated patient, educated clinician competent in home hemodialysis therapy, dedicated and well-educated home hemodialysis nursing staff, and supportive dialysis unit administrative personnel. In addition, it is important to assess patients and their support system for the suitability of home hemodialysis and to recognize burnout. Our hope is that the future will bring more dialysis options to the homes of patients with kidney failure. And thank you.
شكرا جزيلا. ثانك يو بروف منتصر از يوجوال جريت برزنتيشن. انا الحقيقه ليا كومنت بس بسيط. انا طبعا بشكر الدكتور هشام السيد وبشكر حضرتك دكتور هشام لما ذكر في البرزنتيشن بتاعه ذكر على all types of synthetic material we are using and he mentioned also about the physiologic membrane in peritoneal dialysis. حتى لما ذكر الادفانسز الشديده اللي ذكرها في الهيمودياليسيس برضه ذكر الادفانسز اللي في البي دي. لكن بحضرتك بيزيكالي الهوم دياليسيس المفروض بريتونيال دياليسيس ده البيزك الاساسي، يعني احنا ده المفروض احنا بنبني عليه وبنبني عليه بعد كده كل الكونفنشن اللي حضرتك قلته في الهيمودياليسيس. ولا ايه راي حضرتك؟
هو اكشولي طبعا الهوم دايلسيس بيزيكالي هو البريتونيال دايلسيس whether CABD or CCBD or NIBD or whatever type of peritoneal dialysis.
صحيح.
But we encourage also home hemodialysis because of the cost of home hemodialysis is lesser than that for peritoneal dialysis. And actually, you know, the problem of about the absence of the solutions most of the time, and the patients maintained on peritoneal dialysis usually shift to hemodialysis because of shortage of dialysate supplies. So actually, peritoneal dialysis is that of a choice for home dialysis. Home hemodialysis has some obstacles and difficulties, but in Egypt, actually, some patients are maintained on home hemodialysis, actually with conventional machines, because the Tableau and next stage machines are not available in Egypt.
شكرا جزيلا. حد تفضل.
Thank you very much, Professor Dr. Montasser. Your talk is the mirror of your experiences. We thank you very much for that. I have a comment and just a question. My comment, we have different modalities calling either wearable or portable devices that could be portable anywhere you can carry, like next stage in hemodialysis and others, and as well wearable or ambulatory form. We can have ambulatory form like the iHemo in next few years, as well as the ambulatory dialysis for CAPD. And we have a home dialysis, which is usually in Egypt has the fixed dialysis machines. We have plenty of spaces to do water treatment stations as well regular dialysis machine. My question is, who are patients who tell that you cannot do dialysis at home? Just to confirm that not all patients are fitting for home hemodialysis. So what's your opinion on that?
Actually, not every patient is suitable for home hemodialysis. At first, the patient should be motivated at first to perform hemodialysis at home, to be away from the unit and frequent movement to and fro dialysis unit. Actually, we have to select patients and to be sure that there is a motivated partner at home also to help in case, and patients maintained on home dialysis may self-cannulate themselves, but they need to be educated in center for a time till they are perfect in cannulating their arteriovenous fistula. The problem will be easier if the patient is doing dialysis through a Bermicase. Actually, it will be easier, and the infection from Bermicase in home dialysis is, of course, lesser than that in center hemodialysis.
Thank you very much, and that's why intracorporeal hemodialysis is more safer and easier because there is no blood outside, no connection, just to connect sorbent-assisted dialysate fluids. So let us see what's happening in the next decade. Thank you very much, Professor Dr. Montasser. Thank you very much.